Many thanks. Dear President, dear members of the scientific committees, dear colleagues. So, buenos dias, the only word I know in Spanish, so I will have my talk in English. It's a great pleasure for me to come to Costa Rica, and within the next 20-25 minutes I will try to show you our transplant program in France tour, and I also will give you some information why I'm here today. So, well, that's not about the climate. You understood. It's quite. This is tour, and we have still blue sky in tour. I hope that we will still have blue sky for the next couple of years. As I should say that I have no conflict of interest for coming here. Just I was supported by the Institut Français to come here, and I want to thank the Institut Français for supporting my visit to come here, and well, we can discuss about that further later. So I will give you some information about our city, which I believe you don't know very well. Tours is a small city in the south of Paris, 200 miles in the south of Paris. And we have a medical school which is since 50 years. We have about 10% of our population are medical students, sorry. And so we have a high researcher team and staff in Tours and some laboratories. So just to get an idea of our city. And we have some research teams. And in the field of medicine, we have some hot topics, which are medical imaging, the study of therapeutic antibodies, the vaccinology, and specifically on hepatitis B and hepatitis C, we developed the immunizations, vaccination against hepatitis B, cancer disease, infectious disease, and also on the field on transplantation and immunology and neuroscience. So if I came here to Costa Rica, it's because we started to create a program between Costa Rica and our city, and I just want you to know that we are trying to make an agreement between Costa Rica and our university to make students going to Costa Rica, medical students going to Costa Rica from Tours, and medical students from Costa Rica coming to Tours from your university, from UCR. And well, we just built this up, and I think this will be the start of a long history between a cooperation between Tours and Costa Rica. And so we have already organized for 6 students to come here to Costa Rica at the beginning of 2018. And yesterday I met 5 students who will come to Tours for 10-month course, and I hope this will be very, very fruitful for everybody. And so why I'm here today, and I didn't even know Costa Rica very well 1 year ago. It's because there was a cooperation between Costa Rica and for engineers. So there are some engineers who came to Tours before, and the president of the exchange program, France, Costa Rica, is coming from Tours, and so we have quite a little tradition between Costa Rica and Tours, not in medicine, but in other areas. And then we had the demand from Mr. Matthias to create something original in kind of cooperation between France and Costa Rica. And so we have a local liquid, which is wine, which is quite famous, Buchler. It's one of the wine which you can keep the longest in the life, 50 years, 60 years, 70 years, and it's still one of the best wines in the world. And we have no very savage rivers in France, but we have the castles, and this is Amboise, and this is the tombeau of Léonard de Vinci, which is here. So we have some of culture, and we have a little bit nature too. So we want, the next step is to create somebody or something like an exchange with an academic exchange program perhaps to share scientific programs, if ever, in the next 5 or 10 years, and perhaps to have a mobility of the PhD level from our students from Tours coming to Costa Rica, or on the other side, it must be a cooperation. Well, that was just an overview just to give you some idea, because the reason why I'm here, and so I will give you more precisely a talk on the transplantation program of our hospital, and we can discuss about it. So our hospital is a quite big hospital. We have 4 sites in Tours, which are, there's a hospital just for children, and then 2 big hospitals which we call the university hospitals. Most of our students go learning in this hospital, and this is a geriatric hospital. Just to have an idea, we cover an area of about 1.5 million people in terms of the public reference hospital of the university hospitals. There are other hospitals, but we have to manage the main cases for a region of 1.5 million people. We have around more than 2,000 beds in our hospital. We have a technical plateau which is quite okay. We do surgery with robotic surgery more and more. We're one of the first to do it in France. And we have many teaching schools, and we have a big, quite huge research program. So now I'm going to the topic, to the real topic, which is renal transplantation. I will go through that, and I have to explain to you some specificities of the French system, not only of Tours, but of the French system. As you all know, I think that when you transplant a kidney, we transplant just one kidney. It's on the left or the right side, in the iliac left of the right, and we don't as everywhere, we don't leave the native kidneys when we do a transplant. What I should say already is that in France, the transplant program is mostly followed by the nephrologists and not by the urologists, by the surgeons. In other countries, such as the United States or in England, mostly there are the surgeons which will perform this transplantation and make the follow-up. In France, the tradition is that the nephrologist does organize everything, and the surgeon has he makes the operation, but there's a very close cooperation between the surgeon and the nephrologist. So I have to tell you, perhaps you don't know, but the transplantation is one of the things which come from France. France has a high tradition with transplantation, and the first transplantation ever done in humans was done in France. It was made in 1952. We talked about that just before. It was this man, Matthias, Renal. He fell from a roof in Paris, and he had a bleeding, acute bleeding of a kidney, and he went to the hospital in 1952. And well, in such cases, the surgeons, they looked at they had acute hemorrhage, and they opened up, and the kidney was bleeding, and they took off the kidney. They thought that there was another kidney, and that was the fault. There was no other kidney in this young guy, and so he had no kidney anymore. And so very acutely, his mother gave him a kidney. So the doctors said, we have to do something for this young man. And so the mother gave her first kidney, and this was done in 1952, and the kidney started to march, to work. It worked for about 10 days, and then after 15 days, the Marius rejected the kidney, and he died 3 weeks after the transplantation. There were no immunosuppressive drugs. There were nothing was known about how did it work, but it was just to tell you that this is the first human transplantation which worked a little bit, and then this was the first step, and it was done in Necker in Paris by the team of Mr. Hamburger. The second point, which might be very interesting for you to know, is that to understand the transplantation and the complexity of the transplantation system, you have to know that we have many things are based on the immunology and immunosuppressive drugs. And the HLA system was discovered by a French researcher, Jean Doucet, in 1962, and he received the Nobel Prize for this discovery. And just to know that really in France there was a high tradition to work on transplantation. Well, that's just to give you some idea, because in France there's really a tradition about transplantation. And now I'm going to go through a little bit our work in Tours, in my city. And I want to give you some of our results and who we transplant and which kind of patient we transplant. So today in my unit we have, I'm working on the Department of Nephrology and Renal Transplantation. The whole unit is 30 beds, and I have 15 beds which are dedicated to renal transplantation. So it's a quite huge unit, and we have 15 beds for renal transplantation. 4 of them are for people who just are transplanted and are coming up from the operating theater and come immediately to our room. And so we have so it's an intensive care unit, and 11 beds which are dedicated to the people who are transplanted, and we do the internal medicine in those patients, every complication they have. So we have about 4 doctors or professors in this, dedicated to this activity, which is also the follow-up and the intensive care unit. We have many urologists, surgeons, and sure we have to work with anesthetists. I think something which is very important to know is that to do transplantation needs a team, really a team between the surgeon, the nephrologist, but also the paramedical personnel, such as the coordinator nurse, psychologue, which we have. And it's very important that everybody works together on this program. And something which is very, very important too is that you cannot transplant without getting kidneys or organs which are harvested from people who have died, or people who have or living donors. And it's very important to have a cooperation with those who are investigated in this activity of harvesting brain death donors or other donors. I don't know if you know, but now there are heart arrest donors, which are a new kind of donors which are developed. So this is our activity in Tours from the transplant program. We started in 1985. Why in 1985? Because in many French cities, they started a program between 1980 and 1986 because a new drug came out, which was cyclosporine, and the results for this kind of activity were hardly impacted by this cyclosporine, by this new drug. And so we started in 1985. Then we had a period for about 10 years. We transplanted 50 transplants a year, and then we climbed up between 50 and 100, and we do now 140, and we are trying to get 150 this year, kidney transplants per year, which is a quite big activity, because you will see the people will live with a kidney transplant, and it's very specific to follow them up for the immunosuppressive treatment and for everything. And so our cohort of people which we are following, you will see, is growing up, and this needs many medical follow-up. So 140 kidney transplants, why does it increase such increase? So I should tell you that the indication for the transplantation has changed a lot in the last years, and for example, there's no limit in terms of age. When I started transplantation 25 years ago, we didn't transplant patients above 65 years. It was our limit. And then it was 70 years, 75 years. And just know that last year we transplanted somebody of 83 years in Tours. And if there's no comorbidity which does contraindicate any transplantation, we grew up this indication, and now everybody who is until 80 years in France should be referred to a transplant program because it's cheaper than dialysis and it gives a better quality of life. The consequence of this is that we harvest kidneys from very old donors. You cannot transplant everybody if you only harvest very young people, so we harvest people until 85 and 90 years. So, and we have quite good results with a graft survival. We can talk about that, about 2 to 5 to 6 years for people who are 80 years old. So this is quite interesting, and that's a big change in the last couple of years in this program. Another thing which increased our activity is that the indication to perform transplantation has changed a lot. In the 10 years ago, 15 years ago, we tried to transplant only patients who were very well. And now we transplant patients who have co-infection with HIV, hepatitis C. We have more and more patients who survived on cancer and they had chemotherapy which impacted on the kidney. They are on dialysis, and if they have a remission of at least 5 years, now we consider them for the kidney transplantation. So the type of patients has changed with time, and many things have changed about that. So as I told you, this is our activity in terms of transplantation. So we have performed about 2,300 kidney transplantations since 1985. And this is the number of patients who died with a functioning kidney or who returned on dialysis. And so we have lost 840 patients of the 2,200. And you can see that we follow 1,500 patients with a functioning kidney, and if ever one of those patients has a cardiac problem or intestinal problem or anything else, he comes to my unit and we perform the internal medicine for all of those patients, the 1,400 patients living with a kidney transplant. So this is about our activity, but what about our results? And you should know that the transplant program in France is very, very survived and very, there's a government institution which is called Agence de Biomédecine, ABM, which has a survey and which looks at everything which is going on about transplantation. When you perform a transplantation can be performed only in a public health institution, in a hospital in France, and even only in a hospital which works with a university-related hospital. So there are about 33 transplant centers in France, and the activity is centralized at the ABM, and we have to give all our results every year for every patient to show what is going on with our recipients. And so with this kind of work, the ABM, this institution, they publish every year the result of your institution, comparing them to the other institution of your country. So, and it's public. The patients can go on it, but you can compare. And so I give you here the results of our institution of Tours, and to compare it with the national results. And it's a 1 month graft survival, 1 year graft survival, 5 year, 10 years, and 15 years graft survival. And you can compare your results to the national mean, and you look if you're better or less good than the mean for France. And that's an old kind of looking how it works. A more recent one, and it's quite interesting, this is this kind of interpretation which is published now every 3 years by the ABM, and it shows all the center of France. So one point is one center which transplants in France, and on the x-axis you have the number of transplants we performed within 3 years, 4 years, 2003, 2007. So our center is here. We performed about 400 transplants in 4 years, for a little bit more. And the mean survival is about 20% of our transplants are lost after 5 years. And as you can, this is the 96% confidence interval, and this is a 99% confidence interval. And you can see that the program in Tours is that we are significantly lower. We have better graft survival compared to the mean in France. And we have, you see, there's a very big center which is Necker in Paris. This is Toulouse, and we have other centers, but we have quite good results in a pretty high activity, good activity in France. So what about the other kind of specificities we do now in France and in Tours? Because, as I told you, we harvest kidneys from very old donors now, and when they are very old, 85, 90 years, we take both kidneys from the same donor and put the two kidneys in the same recipients. That is is the very old recipient program, and we performed this. We did it 6 times last year, but just to know that from very old donors, we may harvest the two kidneys and give the two kidneys to the same donor recipient, because we believe that only one kidney wouldn't be enough in this case. In our institution, we have also a liver transplant program and a heart transplant program, and we perform heart and kidney transplant, or liver and kidney transplant at the same time for some patients. Since 2 years, we started a program with ABO, uncompatible kidney transplantation, which is done many times in Japan, and we started this. We have to take off the antibodies, and we have something which is the machine which to keep the kidney outside the body, and most of our kidneys are now put on this machine, and this gives us much better results in terms of the ischemia reperfusion phenomenon. And we were the first. We harvest the kidneys from living donors by the robotic surgery. So it's in Tours, the living donors, all the living donors are harvested with the robot surgery, and we made the first kidney transplantation in the recipient with this robot in Europe 2 years ago. So we have a kind of we try to have new techniques to perform transplantation. So what is our main field of interest in terms of research and what we're doing? Well, we are not trying to work on the immunologic monitoring. As you know, the transplant recipients, they need immunosuppressive drugs, and so the pharmacologic effects, we worked on that. We'll work on the monitoring of lymphocyte count in transplantation, HLA antibodies, on the preservation and ischemia phenomenon, and I come back to this later on. But one of the main issues today is when you take an organ and it is outside of the body, to make the best preservation conditions that the organ won't get any harmful injury. We are looking more and more at living donors, and you know that in the United States, living donors are very common. It's about 50% or 55% of the donors. But recent papers have shown that we should be very careful with that, because some of the donors have developed renal kidney disease, and it's really important to work on that. We have one of our fellows, he is specialist in the CMV infection, And we have a research team which works on the dendritic cells and allo recognition. Finally, we have a complete database on our transplant center. So just three, very quickly, those are some of our publications we made, but one of our colleagues, she studied the subpopulation of lymphocyte subsets after use of thymoglobulin, which are polyclonal antibodies which are used. And what we showed that is just that when you, in older patients, recipients, when you use this drug, you keep a low lymphocyte count for your whole life, and so you have a risk of high infection, and you should keep them on Bactrim or some medication for long term. Another work was just on CMV infection. I just know that when you have an organ with CMV and you have a recipient with CMV, the risk of infection depends on the recognition in the HLA system, and the more there's a compatibility in the class 1 HLA, the more there's a risk of CMV infection in the recipient. It's quite confusing, but it's very interesting to understand how CMV works and how there's CMV infection. And very recently we showed, this will come out the next month, that when there's an antibody-mediated rejection, which is a very aggressive rejection, we can predict the result on a kind of what we call CNQ. It's a kind of antibody which fixes the complement. This is just for you to give. We have several works on which is mainly on the field of clinical research. So we participate on many immunosuppressive strategies in our unit, and there are many protocols which are going on. We are working on the prevention of the CMV virus and on the management of the rejection episodes. I want to finish about one thing which I think would interest everybody of you, and perhaps it's one of the most interesting thing in medicine which we are working on in France, and I think you will hear about it in the next 2 or 5 years, whatever your specialty. It's this worm. It's a worm which comes from the ocean, from France, Britannia. There's the ocean, and on the beach you have a worm, which is this one, a small worm, and you will understand why I'm talking about this. This worm is under the water for 6 hours, and it's on. Then the ocean goes back, because there's a big difference between the high level of the ocean and low level, and so the ocean goes back, and then the worm is living for 6 hours without water, not under the water. Is it clear? The beach is going under the water, and this worm is living 6 hours underwater and 6 hours out of the water. And so one of the researchers in France, he asked himself, well, how does he live under the water for 6 hours and out of the water for 6 hours? And he found that this worm has a very strange kind of keeping oxygen. He has not oxygen in his red blood cells, but he has a protein which is which is soluble not in a cell, and this protein fixes oxygen. Okay, it's not in a cell. It's fixed with the oxygen, and this discovering, it was 10 years ago he discovered that. He thought that this protein would be very interesting to give oxygen to tissues who are injured. And so he extracted this protein from this worm in Britannia, and he tried to extract the protein, the specific protein, and we have started. So he did it. He grew up many worms in Holland, And now he does, we have this protein, which is called Hemolyfe, Hemolyfe, and it fixes oxygen in a liquid. And we performed last year the first study where we put this protein into a preservation liquid, still to have oxygen outside of the body. And so we put this protein in the preservation liquid, and the kidney kept be on oxygen outside of the body, because it was with this protein, it was together with this protein. And the results will come next year in the Congress. I don't know the results yet, but what you should know that in all situations where there is ischemia, acute ischemia, infarction, acute brain injury, acute heart, in everything, they are interested in this protein now. And the American Army, they want to get this because you can replace transfusion. If you have acute blood bleeding, you can inject this protein to get oxygen. So I think I just wanted to give you a little bit of, but we work on this with the Britannia. There are many indications for this protein, and so I think if our study will be okay, and if this protein will not be harmful for men, I think you will all hear about this protein within the next 5 to 10 years. So, well, I gave you an overview of what we are doing. So these are the castles in my region. So we don't have the nature, we don't have the ocean, we don't have turtles, we don't have whales, but we have castles. So this is where it's Chambord, the French kings built it up. It's one of the most famous. This is Amboise, where, well, I live just 5 kilometers from there. You're welcome to see me. And you should know that St. Holy Martin, which is a pope of the 3rd century, well, his relics, his basilic is in Tours, so you're welcome to come to Tours. But the most important, I know you don't care about medicine, but you are interested in football. So just think at me, remember me. Next year, there's the championship, and if there's Costa Rica, France, or Costa Rica, Germany, I'll be with you. Okay, so many thanks.